Hello everyone, this is about CT findings in a middle-aged man admitted due to road traffic accident. I am giving 3 questions. First question, what are all the findings? Second question, give the very unusual uncommon finding. The third question, about the uncommon finding, what do you suggest to the anesthetist and the intensivist? If you want more time for the full assessment and for the diagnosis, pause the video and go back to assess the images. Within few seconds, I will give you the findings and discuss about the uncommon finding. Are you ready? Let's go. The given images reveal a depressed fracture in the left nasal bone and also fractures in the zygomatic process and in the medial surface of right and left maxilla with hemosynus in the bilateral maxillary and ethmoid sinuses. Also noted blood products filling the nasopharynx and oropharynx with extensive soft tissue emphysema in the entire face including the bilateral, retromaxillary and the retropharyngeal regions. Pneumocephalus is also noted in the bifrontal regions, left is more than the right, and in cellular and pericellular systems and in prepontine and perimesencephalic systems. All the above findings are the usual traumatic insults in the face and brain. I will talk about the unusual uncommon finding now. There is one air pocket in the spinal canal just below the foramen magnum at left side of posterolateral aspect of C1 level, which is the uncommon finding here. This is called as traumatic cervical pneumorrhachis. We will discuss about the pneumorrhachis, which can be abbreviated as PR here. When I say PR, it means pneumorrhachis here, okay? PR means presence of air in the spinal space, which is an eminent uncommon finding in spiral CT. If it is severe, it can also be seen in lateral view of X-ray cervical spine. For its diagnosis, CT is the imaging modality of choice, and hence this entity has been highlighted not less commonly nowadays, as it is more often diagnosed in the CT decade. PR per se usually represents an asymptomatic, probably underdiagnosed epiphenomenon of coincident underlying injuries and diseases. There were so many synonyms and called with so many names till 1990. They were intraspinal pneumocele, pneumatosis, spinal emphysema, aerorachia, pneumosacus, air myelogram, pneumomyelogram, like that, etc. The differential diagnosis, other than the trauma, presence of intraspinal air can be due to free intraspinal gas collections due to degenerative or inflammatory or malignant lesion, and sometimes gas forming infections can do that, all of which can simulate PR. Rarely there is a coincidence of PR and intraspinal gas, which has also been documented and reported. As a radiologist, it's important to inform the entity to the anesthetist and intensivist while using nitrous oxide as management to such patients with pneumorrhachis, because nitrous oxide can expand the pneumorrhachis, which might complicate further due to the increased intraspinal gas compressing the spinal cord, or it can be sometimes life-threatening by compressing the medulla. Nitrous oxide inhalation is absolute contraindication when there is severe pneumocephalus or pneumorrhachis. Few relative contraindications are there if there is significant positive pressure ventilation in a known case of pneumorrhachis or pneumocephalus, or use of ketamine or succinylcholine, but they can be used if they are more life-saving, right? In our case, PR is very small and use of nitrous oxide might be irrelevant. Remember, in RTA, post-traumatic emphysema in the face can extend to some other borders, like can cause significant mediastinal emphysema or retroperitoneal emphysema, and rarely it can extend to the pleura to cause pneumothorax without any rib fractures and without any chest or lung injuries. Similar way, in our case, it's very rare significant pneumocephalus extending to the spinal canal, which is called as pneumorrhachis, as in this case. PR can be divided into primary or secondary PR. Primary PR is idiopathic and is not discussed here. Secondary PR can be divided into iatrogenic, traumatic and non-traumatic PR. Anatomically, it can be divided into 2 types. One is called as internal intradural PR, where the air is in subdural or subarachnoid space, and the other one is called as external or extradural PR, where the air is in extradural space. Extradural PR is usually associated with penetrating injury and is seen posterior to the spinal cord. Patient is clinically preserved and this PR usually resolves in time after conservative management. But in our case, it's like intradural PR. Intradural PR is usually associated with more severe head injuries and has pneumocephalus and is usually seen in anterior or posterior to the spinal cord. It is assumed to be specific marker of severe head injury or face bone or spine injury. Iatrogenic causes are due to lumbar puncture, spinal anesthesia, or due to spinal surgery, or due to intervention, or due to cardiopulmonary resuscitation. Traumatic causes are isolated or combination of injuries in head or facial bones or spine injuries, especially cervical spine, can do that. Trauma to thorax or abdomen or pelvis with or without injuries to the bony spine might also give pneumorrhachis. Non-traumatic causes are more common nowadays. Example is bronchial asthma, it's very common now. Severe bronchitis, drug abuse, especially with ecstasy, prolonged forceful emesis also can do that, especially in diabetic ketoacidosis. Prolonged acute airway obstruction can also give pneumorrhachis. In our case, the presence of pneumorrhachis might be indicative of severe injury, even though hemorrhagic components are not present intracranially. Also noted that pneumocephalus is present in major portion of basal cisterns and in bifrontal regions. It's very difficult to talk about Mount Fuji sign, which is indicative of tension pneumocephalus. Tension pneumocephalus is indicative of increased pressure in between the frontal lobes or around the frontal lobes, deforming the convexity. In this case, I have discussed about the entity pneumorrhachis, which is rare, and this has to be informed to the anesthetist or intensivist by the radiologist that pneumorrhachis might complicate further if nitrous oxide is used for management, as this can expand the pneumorrhachis and might compress the spinal cord. Okay, thank you very much. If you are interested in the entire quiz list, you can click the blue colored R button and go on to the respective quiz. Take care, all the best.